Dr. Topalian just gave a really excellent introduction to what I'm going to say, and we're going to hit some of the same points, which should give you confidence that we're telling the truth, and also agreeing with Dr. Pardol from this morning as well. And as I said before, I'm very happy to be here and actually see some patients and colleagues, and I think this is a very important type of venue for all of us to participate in. This is a new type of approach to cancer treatment. It's one that is just now beginning to enjoy success, and I think that we need to learn more about it every day. But it has not been a short journey to the success of immunotherapy, specifically to treat melanoma. To give you a little bit more of the background, in addition to what Dr. Topalian provided, many of you know that the eminent journal Science named this field of cancer immunotherapy to be the breakthrough of the year in 2013. But recognition for the achievements of this field were rather fallow, going back over 120 years. And I'll just point to an ancestor of mine in the center there, William Coley, who was the chief of surgery at what was at the time the New York Cancer Hospital, but now is called Memorial Sloan Kettering, who actually first hypothesized that the immune system could be used to treat cancer based upon a really simple observation that when he did surgery for patients to remove their cancer, quite often, because it was the 1890s, they developed infections. And he saw actually that patients who got infections after cancer surgery seemed to live longer. And he hypothesized that those infections were actually leading to the mobilization of some sort of internal defense that was protecting the patients from the cancer. And not much was known about the immune system at the turn of the 19th into the 20th century, but it turned out that he was largely correct. It's just that we didn't have the science to prove it. As Dr. Topalian told you, I think the first major step forward, the first breakthrough before the one in 2013, was actually the development of this medicine, interleukin-2. Also nice to see that, in fact, even that breakthroughs happen repetitively, but also things in Russia and the Soviet Union seem to actually be repeating themselves, unfortunately, as well. But this is the data for high-dose interleukin-2. It's actually data from Dr. Atkins, who you heard from this morning, who actually showed that there was a subset of patients treated with high-dose interleukin-2 that it can actually be cured of metastatic melanoma. Now, it's not nearly as many people as we'd like to see. It's probably somewhere between 2 and 5%, depending upon how you count those folks. But the fact is that people who are in remission from metastatic melanoma at 2 years after high-dose IL-2 are still in remission 10 years later. And so that really gives you an idea of what immunotherapy can deliver when it is successful. We're all vaccinated against things as babies. Our immune systems remember those vaccine responses. And the same, hopefully, is true of immunotherapy, that once the immune system learns to recognize the cancer, it might not be necessary to eliminate every single cancer cell from someone's body. All we need to do is restore the ability of the immune system to hold it back. So that's why those of you who are patients and family members here may hear from your doctor that stable disease is okay. All right? Because as long as it's not getting worse, that is a very strong piece of evidence that the immune system has come into equilibrium with the cancer and has kept it from moving ahead. As many of you know, there was a medicine approved in 2011 called ipilimumab to treat metastatic melanoma. Dr. Topalian showed you the primary data for that. And basically what that medicine called ipilimumab does is it blocks this molecule called CTLA-4, which serves as a molecular brake for the immune system. This is a slide that I use a lot to talk with my patients and their families because immunotherapy is quite complicated. It's taken us over 100 years to even begin to understand it. So how are we supposed to explain it to you, in a couple of hours in clinic? So I'm kind of a gearhead, right? So I like to reduce things to simple mechanical car-like analogies. So the antigen or the target of the immune system is recognized by a receptor on the T cell, and that's very much like inserting the ignition key into the car and turning it. But that's not enough to get the car moving. The car also needs an accelerator, and that accelerator is a molecule called CD28, and that is what really gets the T cell extra activated. When you have a car that has its ignition key turned and a foot down on the gas, if there's no brake, then you're going to run into trouble. And so that is what this molecule CTLA4 is. It's a molecular brake that keeps the T cell from speeding out of control. And what ipilimumab does is it very temporarily, for a few weeks, cuts those brakes so that the immune system can accelerate harder than it otherwise could and overcome some of the immune suppression that melanoma actually throws up in the way of an effective immune response. And so what we're trying to do with medicines like ipilimumab is to cut these brakes, let the immune system function at a higher rev level, and let it recognize cancer. And then you might imagine that, in reference to what Dr. Topalian mentioned, that if you introduced a vaccine at that point, you could steer this now speeding car toward a target of interest on the cancer. So the data for ipilimumab, even going as far back as 2000, was actually quite impressive. That some of the first patients treated at the National Cancer Institute in Bethesda had a very impressive response. So these are CAT scans on top. These dark objects on either side are lungs, and the red circles are drawn around lung metastases. And this is the pre-treatment image, and you can see after treatment all of those lung metastases went away, as did even an incidentally noted brain metastasis, shown here with the arrow, which also went away. So there are some patients who get better really quickly. There are other patients who don't get better really quickly, and I'm going to go into a little bit more detail about this in the talk that I give to the whole group later, but we'll put you guys to the head of the class, and you'll know the punchline already. This is a patient who I treated in the phase 2 trials of ipilimumab, now going back about 8 years ago, and he got the standard 4 doses of ipilimumab. And at the end of the 12 weeks, this is a CAT scan, and this big gray organ here is the liver. And you can see there are a lot more dark gray spots after treatment than there were before. And so, we really thought that this patient was having an example of drug failure. I had sort of prepared other options and discussions for him about what we could do next, but I don't know how patients are here in Chicago, but patients in New York are kind of in your face. So he stopped me in the doorway and said, listen, don't tell me what the scan showed. I have to tell you something first. I feel better. And so I did what any self-respecting oncologist would do. I turned right around, left the room, and made sure I was looking at the right person's scans, because these are not the scans of someone who should be feeling better. And so after convincing myself that I was doing my job properly, I sat down and listened to him tell me why he felt better. And he said that his fevers had gone away, his sweats had gone away, and he had pain in his liver, which also went away. And so it was one of those kind of sort of light bulb moments when you feel like all of a sudden you need a new idea. And the new idea was being had by many of us around the world at the time, that this type of treatment doesn't work the same way as chemotherapy or targeted therapy or radiation, where you expect the cells to stop dividing and the patients to feel better at a very predictable point in time. Here, we're not treating the person directly. We're treating their immune system. And the immune system is what is treating the tumor. And so that may happen at unpredictable points in time. And in fact, these things may actually look bigger because they're not full of more melanoma cells, but perhaps they're full of more immune cells, which is making them artificially look bigger. So it might actually even be a good sign, although I think that's a bit of a stretch. But without any really better answers, and with the patient feeling better, we suggested that maybe he just have another set of scans done about 8 weeks later, which he did, and almost everything went away, and it continued to go away. And he didn't receive any other treatment for the ensuing about 8 years, except for some maintenance doses of ipilimumab as part of the trial that he was on. But this was a strong indicator of the fact that the way that we judge the activity of immunotherapy is different than other forms of therapy, which I'm going to talk in more detail about later. But it also is why sometimes oncologists will suggest to their patients that if they're feeling better, maybe they just want to get another scan done and not all of a sudden change gears to a different treatment, because it may be that the treatment hasn't had enough time to show benefit. All told, when we look at the computer, that's not okay. When we look at the data for ipilimumab, this was data presented by Steve Hody last year, a colleague from the Dana-Farber. He actually presented that just over 20% of patients had survival that lasted 3 years or longer. And so that is higher than some of the data that Dr. Topalian shared with you, which I think shows you what the impact of this type of therapy can be. But it's also a strong indicator that we need to work harder, because that's still not good enough. And that's really where the idea of combination therapies comes from. But again, you see this very characteristic flattening of that survival curve, that people who are alive at 2 or 3 years tend to be alive for a long time thereafter, similar to what we saw for IL-2, but not with as many patients at longer time points, simply because it's a newer medicine. As you heard, there are side effects from this type of approach. They resemble autoimmune disease, but they're not really like autoimmune disease because they don't last a lifetime. They represent a very temporary period when the immune system creates inflammation in different organs in the body. And the most important thing that can happen is that there be good communication between patients, nurses, and doctors and family members. That the sooner we find out about these side effects, the sooner we can intervene with simple outpatient interventions, such as using prednisone or medicines like that, and we can reverse these. Usually about 3 or 4 weeks of outpatient treatment can reverse most of the side effects. But the part in red is really the most important part. But in thinking about what we can combine with ipilimumab in the future, we have had some examples. This is actually the clinical history of a patient of mine who had metastatic melanoma, had chemotherapy, had part of her lung removed, and then had an unresectable recurrence. And these are her CAT scans. And this unresectable recurrence is indicated by the arrow here. And she began ipilimumab in August of 2009. This is showing you her spleen, which is clear at the time, some lymph glands in the chest, and just a funny blood vessel in the liver over there. Over about 1.5 years, things got a little bit worse. There are some dots now appearing in the spleen. These lymph glands are maybe a little bit bigger, and this largest tumor is a little bit larger and was beginning to cause pain. And so because it was causing pain, because this is where the roots of the spinal cord nerves come out, we asked one of our radiation doctors to radiate just that one tumor. And this is showing you a map of where the radiation was given. And that radiation was given in December, January 2011. Right after the radiation, if anything, these scans look a little bit worse. This is bigger, there's more there, there's more disease in the spleen. But then in April, all of a sudden, this gets a lot smaller, these go away, and the spleen is clear. And this is something that has been talked about in the radiation literature called the abscopal effect. And abscopal, I learned from my colleague at Johns Hopkins, Dr. Drake, means shooting from a distance. And that's really what we're doing here. We're turning a single tumor into essentially a site of vaccination by killing it in a very, very specific way, in this case with radiation. And if the immune system is properly tuned in the background, then that vaccination response will lead to the regression of even the tumors that were not radiated. And that's why sometimes when someone is getting a little bit worse on immunotherapy, oncologists may sometimes say, let's radiate one tumor, because maybe we can see a phenomenon like this. And so there are now clinical trials going on combining immunotherapy of various kinds with radiation therapy. In addition, as you've heard several times today, the PD-1 pathway is of great interest to us. And this is another one of these molecular breaks that keeps T cells from getting hyperactivated. And in fact, tumors have co-opted some of the biology of PD-1 in an effort to protect themselves by throwing up onto their surface a molecule called the PD-1 ligand, which actually can cause a T cell to die more easily when it's near the tumor cell. So how clever those tumor cells can sometimes be to devise a way to avoid immune surveillance by killing the very T cell that are coming to kill them. And so therefore it's a very reasonable hypothesis that by blocking PD-1 or blocking its ligand PD-L1, we actually can enhance tumor immunity. And as many of you know, there are several PD-1 and PD-1 blocking antibodies available now, some commercially, some still in clinical trials. This was some of the first data for nivolumab, which is not approved in the US, but is approved in Japan to treat metastatic melanoma. And this was data actually that was first presented by actually Dr. Topalian's group and then updated by Dr. Mario Schnall at Yale. And this shows individual growth curves with the lines going down being patients who are having reduction in tumor size with melanoma treated with nivolumab. And what you can see here is that some of these patients have that kind of funny response, like that liver metastasis situation that I shared with you, where here's a patient who got worse and then got a lot better. Here are patients who are getting better, but new tumors are developing along the way, which go away, even on the way to achieving a complete remission. So we have to be wary of these unusual response patterns with the PD-1 blockade, just as we were with ipilimumab. This is some of the data for pembrolizumab, which, as you know, was approved just about a month ago for metastatic melanoma. And the important thing here, each one of these lines represents a patient's tumor burden increase or decrease. So if the lines are going up, then the drug is not working. If they're going down, then it is. And the yellow boxes are indicating patients who had previously received ipilimumab. And that's really important because, as you can see, there are just as many lines going down that are yellow that there are blue, which means that it doesn't matter if someone did not respond to ipilimumab. They can still equally well respond to PD-1 blockade in this case. So that, for us, is a very good validation of science, but it's a very important source of hope as well. And this is just I think, pivotal data for our field. This was from Julie Bramer from the group at Johns Hopkins, showing that patients with advanced lung cancer can also benefit from PD-1 pathway blockade. So because we've got both CTLA-4 and PD-1, which are showing nice responses in patients with melanoma, we began a clinical trial around 4 years ago looking at the combination of the two approaches in patients with melanoma. And this is some of the data from this clinical trial that first started at Memorial and at Yale, but then opened by Dr. Atkins at Georgetown and Dr. Kirkwood at Pittsburgh, and then subsequently was open in phase 2 and phase 3 around the world. But this is using a combination, the standard dose of ipilimumab and 1 milligram per kilogram of nivolumab. And you can see here that these are very steep drops in the tumor burden in patients treated with the combination. In fact, 53% of the patients treated with this combination at these doses had these really steep drops. And these CAT scans got better very quickly. Each of these orange arrows is pointing to a different tumor that regressed by the first time that we looked. When we look at the overall survival for the patients who were in this admittedly small phase 1 study, we are seeing numbers that make us quite enthusiastic. In the cohort that I just told you about, 3 milligrams of ipilimumab, 1 milligram of nivolumab, the 2-year overall survival rate is 88%. Which is a number that I have to say, as someone who's been treating this disease for 17 years, I really never thought I would see numbers like that. And even if it is a small subset, and even if this is a phase 1 trial, I think it's so radically different from what we would expect that it makes us grin. It really does. Excuse me? There were 53. So this is the total 53 patients treated with the combination, the 2-year overall survival of 79%. And I'll tell you that there will be data available, hopefully, in the next months to year or two from the phase 2 and phase 3 trial, which involved over 1,000 patients. So we hope to have more definitive data, which is comparing the combination with the component parts. There are also trials going on now that are looking at sequence therapy, whether giving one medicine and switching to the other or vice versa is better. So a lot of attention being paid to concurrent treatment and sequence treatment. I'm going to just finish now and say that we now have been looking at multiple different interactions between the immune system and tumor cells. This is something called the cancer immunity cycle, and it was put together by Dan Chen and Ira Mellman in the journal Immunity last year. And this just shows you all the different steps in which tumor cells and immune cells can interact with each other, and things in green that make the process go better, things in red that make the process go worse. And now there are actually medicines in development, some already available, that either stop the bad things or help the good things. And so this is, I think, a very important example of how some success that has been shown already with CTLA-4 and PD-1 pathway blockade has led to deep interest, both on the part of the scientific community, our colleagues in the industry, to help develop new medicines to attack this problem in many different points. So I'm going to finish there. This is my research team here, as well as our funders. These are the folks who largely do the work in the laboratory. And then, as many of you know, this is very important to bring this work to the clinic. And so we have an early phase 1 immunotherapy research team that makes sure that patients get access to these new medicines in the safest and most efficient manner possible. There are individuals in the room who can attest to that, and I have to give them my deepest sense of gratitude for the hard work that they do to make sure that we not only give access to these medicines, but that we do it in a safe and effective way. And finally, to remind everyone that immunotherapy is not something that's so totally new, but it's always been something that has been considered a source of significant imagination. And so even when folks were thinking about tackling the most difficult infectious diseases like polio, immunotherapy was out there as one possible source of great hope that emanated from their imagination. And this is actually etched into the stairway at the Salk Institute in La Jolla, California. I thought it's an appropriate place to stop. Thanks.